Hi, everyone. My name is Jerry. I'm a medical student at Mount Sinai and one of the committee members of the Vascular and Endovascular Surgical Society Discover Interest Group. I wanted to thank each and every one of you for attending our panel today and our amazing panelists who have taken time out of their busy schedules to be here. This is the first event of an exciting student-led project that we started this year with medical students around the nation who are passionate and excited about vascular surgery. We hope we can share enthusiasm with you through this event and for you to consider more about vascular surgery in the future. So our agenda is as follows. On entry, please fill out the pre-session survey. The results from the survey may be used in an upcoming research project, and we'd be incredibly grateful if you take the 2 minutes to complete it. This will be followed by our panelists' introductions and slide presentations, which will take the first 15 minutes. We'll then have a student-moderated panelist question and answer, and then at the end of the night, we'll wrap it up with the post-session survey. Next slide. I'd like to take a moment to also highlight members of our Discover team. Some here are pictured here today. They've spent many hours the past month on this event, and without their hard work, this would not have been possible. Next slide. I'd also like to take a moment to highlight you, our attendees. We have attendees from the US, Puerto Rico, Canada, and the Caribbean. 53% of you are M1s, and M2s represent 30%, with the rest being seniors. We also heard that most of you heard about our event from your local vascular surgery interest group, and it's just fantastic seeing that engagement. Next slide. So I'm going to turn it over to Elizabeth, who'll be now presenting our panelists.
Hi, everyone. Thank you, Jerry. My name is Elizabeth Lavanga, and I'm a second-year medical student at Penn State University. I have the honor of introducing our attending panelists this evening, and we thank them greatly for being here. Our first attending panelist is Dr. Rajani, who attended medical school at the University of Michigan, did his general surgery training at the Cleveland Clinic, undertook his surgical critical care and trauma fellowship at Emory, and completed his vascular and endovascular surgery fellowship at the Cleveland Clinic. He created the vascular surgery section at Grady Memorial Hospital, a public hospital in Atlanta, in 2011, and currently serves as Director of Heart and Vascular Services at Grady. He is also the Assistant Dean for Medical Education at Emory University School of Medicine. His research is primarily focused on the vascular care of disadvantaged populations and novel treatment options for vascular trauma. He is married to an amazing cardiologist and has 2 wonderful daughters. I will now turn it over to Dr. Rajani to say a few words himself.
Good evening, everyone. Thanks for the invitation to be here, and thanks for all joining us. I mean, this is a real amazing thing that I won't say wasn't available when I was making this decision, but I think it's incredible that you guys get this type of exposure. I put some homework together, put some stuff on a slide to just describe the journey. As Elizabeth mentioned, I decided I wanted to be a surgeon around the time that you all are making this decision. I liked it because of making changes with my hands and seeing that change right in front of me. And I decided during general surgery, I wanted to do trauma. I met a really cool trauma mentor that I sort of hitched my wagon to and did some research with, and it sparked this interest, and I decided I wanted to come to Atlanta and learn at Grady. But along the way, my chief year of residency, I did vascular and I fell in love with it. And I met a really cool vascular mentor. And I highlight that to tell you, don't do more than one fellowship. That's just stupid. But more importantly, realize that like it's never too late to sort of think about this stuff and decide that you fell in love with something and be presumably relatively successful with it. I highlight the importance of mentorship, and I think events like this, by all means, and I think I speak for my co-moderators, reach out to us. Like, we love to chat with folks about what they're going into. As Elizabeth mentioned, I practice at a county hospital and Grady Memorial Hospital in Atlanta, where there's a lot of need, and we take care of a lot of disadvantaged populations, and we do some trauma work and a variety of different cases like limb salvage and stroke care and dialysis care. And I'll close by saying the thing that I find most amazing about this is sort of highlighted in the figure at the bottom. Whenever they decided how to split this world up, there was always a medicine doctor and a surgeon doctor who were taking care of the disease process. And there's cardiology and cardiac surgery and neurology and neurosurgery, and it goes on and on. But vascular surgery is really cool in that you never get away from being a quote unquote real doctor. It's not just about the cutting. It's about getting to know your folks long-term and taking care of their medical conditions and being a little bit of a detective to figure out what's going on, while also coupling it with really amazing high precision operations and high technology endovascular interventions. And I think there's nothing like that. And I'm sure we'll talk more about that as we go. Thanks again.
Thank you so much, Dr. Rajani. We look forward to hearing more from you as the night progresses. Next up, we have Dr. Velasquez, and Velasquez is a vascular surgeon at Wake Forest University School of Medicine. She is originally from Mexico City. She completed her general surgery residency at Emory University School of Medicine in Atlanta, Georgia, and vascular and endovascular surgery fellowship at University of Florida in Gainesville. She joined the faculty at Wake Forest University School of Medicine in 2014. A focus of her practice involves the evaluation, management, and open and endovascular treatment of patients with aortic aneurysms, aortoiliac pathology, endoleaks, mesenteric occlusive disease, and peripheral arterial disease within a multi-specialty clinic environment. Her research focuses in these clinical areas as well as surgical education, leadership, and DEI. She serves as the program director for the Vascular and Endovascular Fellowship, as well as director of the MS3, MS4 Vascular Surgery Clerkship. She is a reviewer for multiple scientific vascular surgery journals and is a member of regional and national vascular surgery societies, where she has several leadership roles. She has been appointed as the institutional faculty representative for the Council of Faculty and Academic Societies for the AAMC. I'll now turn it over to Dr. Velasquez to say a few words herself.
Thank you, Elizabeth. It's so great to be with you tonight. Thank you for having us. I know Dr. Berland and Dr. Rajani. I think we just kind of giggle being here because we just are kind of like the old people and just find it so great to be able to talk to you guys. I think my journey was a little bit different from Dr. Rajani in the sense that, as Elizabeth mentioned earlier, I'm originally from Mexico and kind of did all my schooling there. I moved to the US as an adult and came in to do general surgery and thought that I was just gonna go back home. By that time, I had no idea I wanted to do vascular surgery at all. I really fell in love with it when I was a second year in general surgery at Emory, where I found these wonderful mentors. And to Dr. Rajani's point, I felt like the disease process was just very interesting. All of the procedures.
Thank you so much, Dr. Velasquez. We look forward to your insights this evening. Last of our attending panelists, we have Dr. Berland. Dr. Berland is an associate professor of surgery at NYU with 12 years of practice experience. He went to college at Georgia Tech and medical school at the Medical College of Georgia. He then completed a 5-year surgery residency at Mayo Clinic, Jacksonville, followed by a 2-year vascular surgery fellowship at NYU. Dr. Berland is also the host of a vascular surgery show on Sirius XM Dr. Radio with thousands of daily listeners. He received a traveling scholarship during his first year of practice that has allowed him to travel and work with other vascular surgeons around the world for 2 weeks every year. Notably, he worked with industry for the first in-man trials for endo-AVF and was the first vascular surgeon in the world to create an endo-AVF from the wrist. Dr. Berland has numerous publications and presentations in the field. His wife works as an attorney at Spotify, and they are parents to 2 children, Ace, who is 8 years old, and Kai, who is 11. I'll now turn it over to Dr. Berland to say a few words himself.
Thanks, guys. Thanks for you guys for putting this on, and thanks to all the, congratulations really to all of you guys who've logged in here. You guys are all medical students who've essentially made it. The hard part is getting into med school, and you guys have essentially done that. The question is no longer, are you going to be a doctor? You're there, you're going to be a doctor. And now you've got choices to make. What kind of doctor are you going to be? The hard part's over, you're in med school, and now you've got a lot of decision making, frankly. I love vascular, I'm biased, but I didn't always love vascular. I went to med school wanting to be a pediatrician. And as soon as I got to med school, I realized, oh, I don't want to deal with the parents. This isn't what I thought it was going to be. I love the idea of surgery. And to me, cardiothoracic surgery actually sounded like the coolest. So I switched gears. I knew I wanted to operate. It was going to be surgery. And I got into residency thinking I was going to do a 5-year general surgery and 2-year cardiothoracic. And during my 2nd year of residency, one of the doctors kind of pulled me aside. And back in the day, the main journal, the Journal of Vascular Surgery, had all the job listings in the back. He opened it up and showed me Journal of Vascular Surgery, page after page of all these jobs wanted or looking for vascular surgeons. Every state in the country, all over, huge need for vascular surgeons. He's like, don't go into cardiothoracic surgery. All the cardiologists are putting stents in. You're going to do 7 years of surgical training and won't find a job. Go into vascular. The technology's there. The need is there. The baby boomers are getting older. Patients are living longer. Why don't you check out this field? And from that moment forward, I said, wow, this is it. I've always loved video games. So I love the endovascular component of vascular, which you've got to embrace endo in this specialty. And the world of vascular surgery has so many different things, from venous to arterial to mesenteric to aortic to dialysis access you could really specialize in any one of these. And as your career progresses, you could kind of curtail it and do the things that you want. So the field of vascular surgery is really much bigger than you would think. It sounds like the super highly specialized field, but there's really so much within that field of vascular. And like Dr. Rajani mentioned, we're kind of the vascular doctors. We kind of manage the medicine part of it, and that's really what makes it cool. Looking forward to having a chat.
Thank you so much, Dr. Berland. I'll now hand it back to Jerry to introduce our trainee panelists this evening. Thank you.
Next will be Chris Audu. Born and raised in Nigeria, Chris is a PGY6 vascular surgery resident at Michigan Medicine. He attended Purdue University for college, completing a bachelor's in science and chemistry. He then completed his MD at Dartmouth and also his PhD in chemistry at Dartmouth. During surgical residency, his research endeavors have led to 2020 Vascular and Endovascular Surgical Society Resident Research Award and an NIH F32 grant investigating the impact of Notch inflammatory pathway inhibition on wound repair pathophysiology. His research interests include intra-arterial calcification, critical ischemia, diabetic wound healing, drug development, design and delivery, and practice-changing clinical outcomes research. I'll turn it over to Chris.
Thanks for that introduction, Jerry. I appreciate it. I just want to echo what everyone has said. Welcome. Welcome to what really is an exciting field of medicine, being vascular surgery, and the things that we get to do. And I look forward to interfacing with all of you, and at some point being able to answer whatever questions you might have. Yeah, welcome.
Thanks, Chris. Next is Aron. Aron's a fourth-year medical student at Brown University, applying into vascular surgery. He's originally from the New York suburbs and did his undergrad years at Brown as part of a program in liberal medical education. In his free time, he enjoys playing cello, hiking, and playing basketball. Aron completed away rotations at the University of Minnesota, Mount Sinai, and Georgetown MedStar, and is excited to be applying into vascular surgery this year.
Thanks, Jerry. Hi, everybody. I'm Aron, fourth-year medical student from Brown, like Jerry said. In terms of how I got into vascular, I do think that coming into medical school, I was a little all over the place. A lot of people tell you to pick between surgery and medicine pretty early on. And I had a lot of trouble with that dichotomy because I sort of felt like I wanted to do both of them. So I explored fields like emergency medicine, hem-onc, ENT, and ophtho, things that would allow me to work with my hands while also maintaining relationships with patients. And early on in my third year, I took a vascular surgery elective. And that's when I realized that this was really the specialty that allowed me to do all of those things. Like Dr. Rajani said, you get to be both the medicine doctor and the surgical doctor for your patients. And something else that I think I really valued was long-term relationships with patients. And for better or for worse, a lot of vascular patients do follow up long-term with their doctors. And then I think I also was a little worried about being bored, to be totally honest. And in vascular surgery, you get to operate all over the body and you see all different kinds of acuity. So I think that's really what's led me into vascular surgery. And I'm really excited to be applying this year.
Thanks, Aron. So next we're going to move on to our moderated question and answer session, so we can stop sharing the screen. So the first question will go for Dr. Rajani. And the question is, why should you as a medical student choose vascular surgery?
I get an hour or so to answer that, right, Jerry? We've touched on some of this. I can tell you it's the best job in the world, and I'll get back to that in a second. But I think ultimately, at the end of the day, and Dr. Velasquez and Berland will agree, our job isn't to convince you to go into vascular surgery, right? Like at the end of the day, our job is to make sure you know what it means and to think about whether it's a good fit to you. So I'll tweak it a little bit and talk about the types of things that may interest you to go into this field. And I think there's lots of great things to go into. And my wife's a cardiologist, and you'd be surprised how often at the end of the day, dear, how was your day? It's pretty much the same day, except slightly different. Once you finish your training and get through stuff, you take care of some patients, you take care of some trainees, and you do all that sort of stuff. Ultimately, we've touched on a couple of big ticket items, though. One is the idea that taking care of the disease process as a whole, and not just the surgical aspects, I think is part and parcel with what our DNA is about. And one way I'll make that sort of more concrete is if you go to a surgical clinic and you see, let's say they see arbitrarily 20 patients in a day, you actually get a pretty good sense of the type of field it is based on the number of cases that are booked out of those 20 patients in a given clinic. So a cardiac surgeon, for example, wants to book 20 cases out of those 20. They want to be sent patients by a cardiologist who really need an operation, and their focus, which is really cool, is mastering that operation. It's not uncommon that I'll see like 20 people and I'll book maybe a couple of cases, but so much of what we do, and hold on, it's actually better than it sounds, is longitudinal care where we are watching people's aneurysms. We are watching their dialysis function. We're making sure that their long-standing peripheral arterial disease is doing okay, that their carotids haven't gotten worse where it puts them at risk for a stroke. And I can't even begin to explain how meaningful it is for those 20 patients to get to know them and their families over a period of time and manage much of their care. Part of that has to do with the environment that I work in, that there isn't a lot of great access to care, which is increasingly true across this country. But a lot of my patients think I'm their primary care doctor. I have to pretty strongly tell them that's the most ridiculous thing I've ever heard. But you fill a similar role in their life. And you have to be willing to buy into the idea of being the real longitudinal doctor. And at the end of the day, if you take someone's gallbladder out, they only got one of those to take out, and you don't have much to do with them. It's very episodic. This is surgical care that's longitudinal because the disease processes happen together. All of the risk factors drive all of the same disease processes. One patient will have an aneurysm and maybe claudication and carotid disease and ultimately go on to renal failure, and we're there for them every step of the way. That's the one big piece that I think is really important to understand about our field. And then the other one is this idea that I'll tell you at the end of the day, when I was interviewing, I gave all these answers that you guys are going to have to give, and it's really important. But in retrospect, why did I do this? If I were brutally honest with you and myself, it was important for my ego to do a field that was technically demanding. I had to do something that made me feel like I was the best of the best technique-wise, and that was going to push me to be that type of physician. And I think vascular surgery does that because the work that you put in over the years with your hands have meaningful results. I'm better than I was yesterday. I'm certainly better than I was 10 years. And I hope I continue to be better every day of my life, because once that curve goes down, it's probably time to do something else. But that idea of being technically respected and master your craft from a fine-tuning standpoint of what you can do with your hands, coupled with that idea of broad-based care, I don't think you can find that anywhere else, because you're either just focusing on one operation, or you're doing a bunch of operations but not really providing longitudinal care because it's episodic. And I think that makes vascular incredibly unique. For me, those are the types of things that if they sound appealing to you, there's no field you're going to find that meets that. There's really not.
Thank you for that answer. The next question will be from Prashant.
Hi, everyone. My name is Prashant. I'm a fourth-year medical student at George Washington in DC, also applying to integrated vascular this year. I had a question for Dr. Rajani and Dr. Berland. Can you walk us through a typical week in your clinical life, including the types of cases you do, your admin obligations, your time for research, and anything else you think is pertinent?
Sure, happy to talk about that. The beauty of this is, as a med student, as a resident, you're kind of told where to be and when, and there's a lot asked of you. As you kind of become an attending and start working, you're kind of an adult and you kind of run your own schedule. So I'll tell you what I do on a week-by-week basis, but it's the schedule that I created for myself. And if I want to make my kids 12 o'clock, play that he's in, I'll shut my office hours down, or I'll block out some time and do it. And that, you can't do that as a med student and resident, but you do have that in life. And I think one of the thoughts is, it's so demanding, you don't have that family life. That's an old school mentality. It is what you make of it. And in this day and age, you can have it all. I do think that is true. You can be the surgeon and also be at home and be available. My day-to-day, Mondays, I do all endovascular procedures. We have an office-based practice where we do procedures, multiple endovascular procedures, and I do those on Mondays. Love that. Tuesday is my main OR day, and I'll do everything from an aneurysm to a carotid, to any kind of open kind of peripheral bypass, dialysis access creation, amputation if it needs to happen. Some complex deep venous disease, some of the deep venous problems that are going to need multiple stents. We don't do those in an office setting. We'll do those in the main OR. Wednesdays, patients all day long. I'll see 30 patients. Dr. Rajani was talking about that longitudinal care. I love that part of it. That's why, I think vascular is so appealing. I'll see 30 patients, and I just think of medicine docs who that's their everyday. That's my Wednesday. And if you're in medicine, that's your everyday kind of lifestyle. I'll see 30 and probably book 4 or 5 procedures out of those 30 patients. So it's not like I'm seeing 30 patients and booking 29 procedures. So there's a lot of patients that are coming in for follow-up, some new patient visits that just are going to require follow-up. So I love those days. Thursdays, I kind of have a mix between vein procedures and endovascular procedures. And on Fridays, I'll kind of toggle back and forth between a full day of office hours again, or my office-based practice doing endovascular procedures.
Yeah, I'll briefly just piggyback. Dr. Berland is 1,000. I can't agree more. I mean, you'll have such an incredible degree of control over your life that is hard to envision what that means right now. Listen, there's sacrifices, right? If you say, I want to be a cardiac surgeon, but I only want to work 1 day a month, you're probably getting a pay cut if that's your plan, right? Or there's going to be something that you have to sacrifice. But you'd be surprised how, like, the whole lifestyle piece that I'm sure we'll talk about more is a really interesting concept. Your life is going to be hard during residency, whatever you go into it. They're pretty homogenous and they're all pretty tough. Once you become an attending and you find what appeals to you, you will forge your situation around what your life needs out of it, quite honestly, whether that be what your family needs out of you, or your parents need out of you, or whatever you personally need out of it. And that's really important to rush through it. I've picked up a lot of administrative responsibilities in the last year. So Monday is a big education day for me, helping to forge what the education platform at Emory University looks like and how we're changing it. Tuesday is my clinic day, and it's been my clinic day my entire career. And Wednesday is my big OR day. I'll usually have 2 rooms and a fellow and be able to bounce back and forth. Thursday, I do an outreach clinic about 45 minutes away from the hospital, which is a really nice, smaller clinic. It's low acuity, but it's a really nice longitudinal place to hang out with primary care docs and get them to refer low risk problems and so forth. And then Fridays, I'll either be operating a little bit or covering for one of my partners, or a lot of time that's some research time as well. Call is interspersed throughout there, as you can imagine, and call is very different depending on what type of hospital you're at. But you absolutely will and can tailor what your week looks like to what works for you.
Thank you.
Hi, so I have the next question. My name is Maura, and I'm an MS2 at Rutgers Robert Wood Johnson Medical School. Our next question is for Dr. Berland and Dr. Velasquez, and this may be an extension from the previous question, but what does work-life balance look like, and how do you manage your professional and personal commitments?
Well, I guess that question is really kind of answered by my last time. As you graduate into adulthood and attendingship, you've got control over your schedule. You not only can you do and see the things that you want to see and create your own schedule, but you could take that time off. You can't do it now, but you'll have that time available at the end. There is a light at the end of the tunnel after all this hard work between med school and residency training, that I'm able to do all the things that I want to do. I don't feel stressed for time. I don't feel like I'm not getting enough sleep. Now, certainly there's nights on call where we don't shut down our next day, because sometimes on call, I won't even have to go in. It'll just be a night on call. And then the next day I'll go back and, do whatever I had planned for that day. So I don't shut my next day down. So sometimes I get a big hit and I'll be up all night operating and don't have that luxury to shut down the next day. Sometimes I could ask one of my partners if I've really been, if I'm really exhausted, to kind of spring me. But for the most part, you kind of get through it. And you guys are at this point working the hardest. It does get harder as you get older to pull those all-nighters. I used to think nothing of it. When I was younger, I was like, give me more, I'm fine. Give me every other night, I'll do it. And now as I, get older, I'm like, God, these they're getting a little bit tougher. But for all in all, just like every specialty, I think the rumor is that vascular is terrible. It's really not. Vascular is awesome, and you can, if you're in a big practice, your call may be very infrequent. If you're going to a small town where it's just you and another person, or maybe 3, you're going to be Q3, and that's going to be a little bit different. So I think it really matters where you are as far as what your lifestyle is going to look like.
Yeah, so I would say I kind of think it's interesting, these like lifestyle questions, because I really don't believe there's an actual balance. It's really more like of integration. I don't know, maybe Dr. Rajani and Dr. Berland are different, but I've never been able to be 50-50, not in, I gotta work, working home, and not with like my husband either. My husband is a cardiologist as well, and we have a couple of little ones. So I think it really matters the practice you join. Vascular surgery can be hard in the sense that we deal with sick patients, and in the sense that, you're taking care of people and you're responsible for their care, and it can be stressful at times, but not any different than any other specialty that, takes care of folks in general. But it really depends on your practice, on the partners that you have, and how many people are in there to be able to kind of rearrange things so that you can be present to what you want to be. I do believe that there's different stages in your career. I remember when I just started, I was so aggressive. I wanted to be operating all day, all night, because I felt like that was what's going to give me, like this confidence, and wanted to just make sure that I felt like really good about taking care of people. And at that time, I didn't have kids and so forth. So I was like, nobody needs me. I mean, I guess my husband did, but, he was working hard too and so forth. So that was kind of like the time when we were like just in the hospital all the time, and, meeting patients and so forth, and working on your academia and your research and all those things. But then, as your life changes and other opportunities come your way in terms of your career development, in terms of your professional endeavors and your family needs, you really have to make some adjustments. And you really have to say, okay, do I really need to, kill myself to do this, or do I really need to invest in myself to develop myself professional? My kids need me, this particular season. I need to be, more present with them and be more intentional as to what that means, and that it comes to, rearranging your schedule or blocking some clinics or making sure that you're present there. So you really have to do that, because if you don't, you're going to be in the hospital all the time. I'll tell you this, like, the work is going to be there every single day, every single night. If you want to kill yourself at work, you can do it. But I think that's true for every specialty, right, that takes care of people in the hospital. We do see emergencies. So, when you're on call, you're going to come in and operate and so forth. But you really have to take care of yourself and be in a group that they take care of each other. And that's the beauty of vascular too. Like, honestly, I'm surrounded by great people. So that's the other thing why we're vascular surgeons, because, like, if I was to join a group with Dr. Rajani and Dr. Berland tomorrow, I know that I'll be in good hands. And I know that I will help them, and I know that will help me. And that's sort of like how we work. So I think that this lifestyle question is really very much about what stage in your career you are, what's important to you, what are your family needs if you have family, or if you don't, also, you have to take care of yourself. At the end of the day, just think that it's a privilege to take care of these people. You're going to be working hard towards it, but also in order to be able to be the best doctor you can be, you have to take care of yourself.
Thank you so much for that insight. And I think our next question is from Thomas.
Hi, everyone. I'm Thomas Chang. I'm a fourth-year medical student at Boston University, and I'm currently applying to vascular surgery. To change the subject, I have two questions for Dr. Velasquez and Aron. How does vascular surgery overlap or compare with other interventional medical specialties or other surgical specialties? And the second question is, what does the collaboration look like at your institution?
Right. So for the first question, as I mentioned earlier, when we were doing the introduction, vascular is one of those specialties that you get to collaborate with a lot of other specialties. And there is some overlap because of that. The need for vascular surgeons, as we were talking about earlier too, is so high, so demanding. There's a lot of underserved areas, and vascular disease is everywhere, as you know. So all other specialties we're gonna, pitch in to take care of these people. Call it interventional radiology, call it interventional cardiology in general, will be the ones that we will overlap the most. A lot of the times people believe that that's kind of a bad thing to say, oh, they're competition. I'm married with one of them, and Dr. Rajani is married to one of them too. I really think that if you see it that way, you're gonna be kind of not happy, because the truth of the matter is that we're trying to help each other to take care of all the people's needs. In my particular institution, we are very collaborative with both interventional radiology and interventional cardiology. We help each other a lot. We call each other a lot, and that's how we do. We never see it, as a competition. If there's a couple of interventional cardiologists that want to do peripheral work, that's great, as long as they, we talk to each other. And that's why it's important to collaborate, because they know that they will talk to us ahead of time, say, hey, I'm gonna be doing this, or if they have a question while they're doing that is fine. They take good care of people. They're really good doctors too, but we should never really see it as a kind of like as a competition itself. So collaborations at my place, Least Wake Forest, is a very collaborative place. We have very big services, very sick people. So I think that that really helps all of us to be able to help each other, and this overlap not seeing as something that it could be a disadvantage, but to the contrary.
Yeah, I took an interventional radiology elective during my third year. It was one of the specialties that I was considering along with vascular. And I really enjoyed it. They do really cool stuff. I think there is definitely some overlap with things that vascular surgeons do, especially in sort of peripheral arterial work, angiography, stents, that sort of thing, and also some of the venous work with IVC filter placement and other things like that. But at least at my elective, the interventional radiologists also did other procedures, like chemo drug infusions, needle biopsies of different masses, lumbar punctures. So there certainly are distinct fields. At least for me, I think what caused me to choose vascular over interventional radiology was sort of twofold. First, the interventional radiologists, they do still do everything under image guidance. And in vascular surgery, we get to do things under image guidance, but also just sort of general traditional open surgery, which is something that I really enjoyed. And then I think the other thing for me was that, at least at my institution, interventional radiology is really mostly a consult service. And they're sort of being assigned patients and performing biopsies and helping out. But they don't really have their, sort of quote unquote own patients. And I really like that in vascular surgery, we get to have our own patients that we take care of and see longitudinally. But yeah, no, it's super cool field. I think for those reasons, that's why I chose vascular surgery.
Okay, thank you. And the next question is by Thomas.
Yes, thank you everybody for all these questions so far. It's been really great. This next one is going to be specifically for Chris. So we were wondering, did you ever consider going into another field of medicine, and what influenced your decision finally to pursue vascular?
That's actually a very good question. So the answer to that is yes. I think everyone at some point you make a decision whether to do surgery or not. I actually considered other procedural fields and actually even considered a non-procedural field like neurology as I was going through medical school. What drew me to vascular were multiple opportunities, as has already been said, to do interventional type work, but also do open surgeries. But for me, there was also the added aspect of being able to engage in really fundamental basic science research. And so what I did as a medical student was I went to different conferences. So if I had a field that I was interested in, I would go to their national conference. And I remember going to the Society for Vascular Surgery annual meeting, and it was in Boston that year that I went. And I just walked amongst the posters because I was just asking myself, what sort of projects are the residents doing? What are the questions that are being answered? What's the patient population in this field? And every time I walked along amongst the posters and spoke to the presenters, it just reaffirmed that this was the field for me. There were people who were doing practice changing clinical work. There were people who were doing disparities type work. I saw that the patient population in vascular ranges from people who are very rich to people who are very poor, and the disease process of what we see ranges from vein diseases to people who are super sick and need big operations. And so I think for me that was a huge tie, but in particular in my situation, I was also looking for a field that would embrace me as a basic scientist in surgery, and vascular surgery kind of checked all those boxes for me. So I think having a field that checks the box of clinical expertise, patient population that you will work with, and then whatever other niche thing that you're interested in. For me, it was research. If yours is education or innovations, whatever, just to find a field that will welcome you and for which you would feel like family. I think that's important. And it's been a great ride so far. I'm PGY 6 out of 7, so I've got another year and a half to go.
I have the next Next question. I'm Cayetana Lascano. I'm a second year med student at Ponce Health Science University in Puerto Rico. And this question is for Aron and Dr. Berland. And it's, what are your favorite and least favorite aspects of your career in vascular surgery?
I think in terms of my favorite, it's got to be, from what I've seen, it's got to be the long-term relationship with patients. I just think that going into this, I seriously looked at hematology oncology for a while, just for that sort of long-term steady relationship. And that's something that I was really looking for in a more procedural field. And that's something that I was able to find here. I know Dr. Rajani said we're not primary care doctors, but I do think it's cool how you get to see patients again, regularly, every couple months, every year, follow up with them, and also get to operate. And I think marrying those two worlds sort of perfectly is probably my favorite thing about vascular surgery. As for least favorite, I think I'll defer that to my more experienced colleagues.
No, that's a great question. There's a lot of things that I like about it. One of my favorite aspects is that you're the surgeon's surgeon. So when we get called for emergencies, it's from other surgeons, whether it's neurosurgery doing a spine exposure, GYN doing something with the uterus. These other doctors get into bleeding, and who do they call? They call vascular. That's really cool when you're the person that comes in there to fix that hole in the artery and save the day. That's also my least favorite part of vascular surgery, because that never happens at a time when you want it to happen, right? These things just pop up. You never really know when it's going to be, and it's never the right time. But you kind of drop what you're doing, you prioritize, and you kind of take care of these problems. And it's really cool to be empowered and have the knowledge and skill to be able to fix holes in arteries that otherwise would kill a patient. So that part's really cool. Secondly, the technology. I mean, if you have any inclination to love the tech, vascular surgery kind of has, an exploding arena between stenting, drug-coated technologies, different delivery devices, and there's incredible opportunities to collaborate with industry to really advance the science. So if you're into that kind of thing, you're doing these procedures, you're hands-on, you're in the OR, you're doing these procedures, you've got the ideas to make things better, faster, slicker, and by working with industry, you can kind of make these things happen pretty quickly. So I think that's one of the best parts of vascular is the technology.
Awesome. Thank you very much for this insight. I hand it over to Liana.
Thank you everyone for being here. My name is Liana. I am a second year medical student at Penn State College of Medicine. My next question is towards Dr. Rajani and Dr. Velasquez, and it's, how did you become a vascular surgeon? Did you go through the 5+2 or 0+5? And in your opinion, is there any advantage of doing general surgery before a vascular fellowship?
All right, well, I did the traditional training that we call traditional. It's not really traditional, but just sort of like how it started. I did 5 years of general surgery and then did 2 years of fellowship. I loved it. I honestly just love my general surgery experience. I did not know I wanted to do vascular surgery. So I really just enjoyed having all that exposure to all of the general surgery subspecialties and, treating all kinds of patients and so forth. So kind of really loved becoming a surgeon. And when I was my chief year, I really loved it. It was a really good experience. And then, the 2 years of vascular surgery were intense. They were really intense. They were really intimate and lots of learning. Like you kind of come out of general surgery like, oh, I kind of do it all. And then just like your first day of there, you're a dummy. You don't know anything about it. So it's kind of like a huge, like going down and kind of like trying to climb up that ladder. But I don't regret it. I don't regret that at all. In terms of if I think that there's one better than another, I don't think that there's one better than the other. I really just think it depends on your interest, right? Unfortunately, a lot of medical students are not going to be able to know what they want to do surgically right away. And then they may not have any exposure to vascular surgery. That's what we want to change. We want to make sure that they have some sort of exposure, know what exactly, show them what we exactly do so that they know that they could do that, because a lot of them just want, or they do it, towards the end of their, MS4, and by that time they feel that they're, it's so competitive, I'm not getting. So I think with the advent of integrated programs, I think it's phenomenal. You guys are incredible. You guys are great. You're so equipped and so competitive that, we all want to, train you and, you guys will be our bosses one day. So really feel like both options are great. And if you already know you want to do vascular, go for it. You start doing vascular from day one, which is awesome. I honestly don't miss the colon, don't miss the gallbladder, don't miss the hepatic resections. I don't miss any of that. We do enough belly surgery to be around that area, you know, but don't need to be doing all that. So.
Yeah, I'll echo. I mean, I did 5 + 2 don't do that. That's just a really bad idea. I did 2 extra years of fellowship. I don't like noise. Like I like keeping things simple. And I worry sometimes, especially at the med student level, it's so easy for someone to get in your ear and create noise. So both 0 and 5 and 5 and 2 are great. They really are. And there are reasons to do one versus the other. I like to highlight the reasons that people hear that aren't true. So sometimes you may have heard that you should do 5 and 2 instead of 0 and 5 because it's better training. That's the stupidest thing I've ever heard. That's not true. We've shown that over and over and over again. That's not true. But you'll still hear it from time to time. You might hear from time to time that you should do 0 and 5 because by the time you're applying for fellowships, there may not be any fellowships left. That's also the stupidest thing I've ever heard. Those two things are noise. Those are not true. You should do integrated vascular if you're 100% sure you want to be a vascular surgeon. You should absolutely do it. If you're 99% sure, maybe you shouldn't, because it's really amazing. And I think you heard Dr. Berland's story, my story, Dr. Velasquez's story. None of us were medical students wanting to do vascular surgery. And the reality is, you all know this, there's only so many things you can be exposed to, right? Like I might have been meant to be the world's greatest radiation oncologist. I still don't know what radiation oncologists do. Like I never did that rotation, right? I don't know if that was my calling. If you need more exposure, do 5 and 2. If you're 100% sure, do on 5 and you'll get the same training. And if you do 5 and 2, you'll still get a great fellowship. That's noise and should go away.
Amazing. Thank you guys so much for your response to this. I think the next question is going to be done by Lucy, so turn it over.
Hello, I'm Lucy. I'm a third year from Case Western. My question tonight is for Chris and Dr. Berland. How do you foresee the field of vascular surgery changing in the near future, and then within maybe the next 10 years or next few decades?
I guess I can start and tackle that. Vascular surgery, one of the enticing things about this field is that it's always changing. So for example, 20 years ago, endovascular options for aortic aneurysm repair were not as sophisticated as they are today, and most people got an open repair. Today, if you walked in with a favorable infrarenal aortic aneurysm, chances are that you will be offered and get a good and solid endovascular repair. And so I think that not only has that paradigm shift happened, but also the technology that goes along with it happens. And there's only more that's coming along the horizon. We're constantly seeking innovations that will help our patients and that will provide for them treatments that are less invasive, but also durable. So that's one thing. The other thing is, there's people who are doing, who are, I guess, interested like me in really advancing the vascular armamentarium of medications that are available for us, for people who have critical limb ischemia, who suffer from diabetes and just can't get blood flow to their limbs, et cetera, et cetera. So I think that that's a new area that's gonna blow up within the next few years, hopefully. And then you also have just education. So I think have things like education and mentoring. We have a lot more people entering the vascular workforce these days, and it's very diverse group of people entering the workforce these days. So I think having mentors that are able to speak to you in a way that kind of get you in that sense is going to be even more critical for vascular, and that's going to be a way that the field changes and evolves and even gets better in the future.
Very well said, Chris. I'll echo a lot of the same, starting with the pharmacodynamic part of this. It's amazing to me. I was trained in the era of like Lovenox and Coumadin, and when DOACs came on board, it was like, wow, you can give this kind of blood thinner and not have to check anything. That just seemed crazy. And now to look and see that factor 11 inhibitors are on the horizon, where you've got a medication that can attack the extrinsic pathway for coagulation and prevent blood clots, but not have any issues with increased bleeding, particularly during surgery. You could do a giant surgical operation on one of these medications and not experience any more bleeding. That is just crazy to me. And that's just right around the corner. Where we're going to be in 10 years, I think I can't even imagine where the medicine side of it's going to be. But I will say, I remember thinking about this early in my career, probably about year 3 or year 4 out from training, probably about 80% of what I was doing I was not doing as a fellow. And now being 12 years out, probably 90+% is different. And so that's why you're constantly evolving. Aside from like an open carotid endarterectomy, maybe a surgical fistula creation and a baloney amputation, that you kind of get during training, and you get faster at those and a little bit quicker and probably a little bit technically better, but that operation doesn't change. The endovascular part is constantly evolving. And so that's really what changes. So every few years, the whole armamentarium changes. The devices are different, your approaches are different, the access vessels are different. So it's really amazing. And that's one of the cool parts of vascular. It doesn't get old.
Thank you both for your responses. I'm going to turn it over to Thomas, who is going to introduce some special guests for us.
Hi, everyone. So we just have a few rapid fire questions for anyone on the panel to answer. So our first question is, what would you like to see change in the field of vascular surgery?
I think the most important thing that we've touched on a lot of things a few times. I think a couple of really big things that we haven't touched on is how quickly vascular is emerging in the center of the conversation around health equity. And it's really remarkable how we've touched a little bit on diabetes-associated foot care and access to care, but more and more you see that being a huge part of what we're about. I think we have work to do to emerge as leaders in that space, that vascular care is health equity in this country. And it is improved if we are more diverse in our workforce, if we embrace our role in the direct care of patients who don't have anywhere else to go. I think that is the thing I would like to see us continue to push forward in.
Okay, thank you very much. And is Lena on?
Yes, the next
So real quick, just to jump in, sorry to cut you off there. I just wanted to introduce a special guest that we were not actually expecting to have. We have Dr. Peter Nelson actually who's present today. And just a little bit about Dr. Nelson. He is chair for cardiovascular research and chair of the professional and section chief of vascular at Oklahoma University. And he served as the program director of the vascular fellowship at Oklahoma University. And he's somebody very passionate about student education and recruitment. And we are hoping to maybe get some of his insights.
That's all very kind. Can you guys hear me?
Yes.
I'm in the car, so sorry about that. But and I'm probably not so special a guest, but I appreciate the introduction. So I want to echo what Todd said. Vascular is awesome. That sums it up right there. And I appreciate the turnout tonight is amazing. I appreciate you all tolerating a PGY 30 on the call. But I have to be honest, your speakers tonight, your moderators are some of my very, very favorite people in vascular surgery. So I had to tune in. So it's a great session. So I'm happy to answer any questions, but you guys are in good hands with the leadership you have here.
So I guess I'll go ahead. Thank you so much, Dr. Nelson. And I would ask the last question that we have for the rapid fire. And that is, what is the toughest aspect of your job? Dr. Nelson, if you can just pitch in for us with this one.
So the toughest aspect of my job, in some of my recent roles, I've taken a lot more administrative responsibilities, and I did that intentionally. I love it. I love being someone who it's not so much about me anymore. It's about my junior partners and recruitment and fellows and residents and students. But there are times where I feel like, I love the surgical aspects of being in the operating room of what we do. And sometimes I sit in administrative meetings and I think, gosh, I wish I was doing doing an aneurysm right now. The good news is I'm actually driving home from work right now. I did an upper extremity axillary brachial bypass on a young lady with very complicated problems. So that's not something we do every day. And then I'm going to go home, have dinner with my family, let my dogs out, and then turn around and do a fenestrated EVAR tomorrow morning. And, you know, it's the spectrum of what we do, the complexity, but the excitement of what we do is just amazing. And so I'm tolerating the administrative things because I think it's important. We do need to advocate for ourselves, either with the hospital or with our, university administration. And so I'm happy to do those things. But, being in the operating room, I think is where we all really enjoy our time the most.
Thanks, Ann, and thanks, Dr. Nelson. So the final question for tonight's panel is for everyone, and I think if you can say 1 or 2 sentences each, that'd be great. What is the single most important thing a medical student can do to prepare for success in vascular surgery?
I'll go ahead and start if that's okay. I think it has nothing to do with anything vascular related. This is once you start your vascular residency, you're not going to really look back at peds, GYN, neurology. So pay attention to all those other things. Be a star in all those other different subspecialties and rotations that you go through, because you're never going to see those again. You'll work peripherally with them, but you'll have enough time to focus on vascular when your vascular residency starts. So just focus on being a good doctor.
Yeah, I will echo that for sure. And also be yourself, okay? Just be genuine to who you are. If vascular is really in your heart, work hard for it. And you do everything you think you need to do to, check all those boxes, but never lose yourself in the process. Just because you like the idea of being a vascular surgeon doesn't mean that you have to be one. So if you love it and you really want to be that, just be yourself and you'll do great. And we can't wait to have you be part of our workforce.
Yeah, I think be fearless. It echoes the same things. The stuff that's worth worrying about is worth worrying about, but most of it's not worth worrying about, and most of it's noise. And you're gonna have to give up your hobbies and your work-life balance. That's all nonsense. Just be fearless about the decision and do it and enjoy it. Honestly, that's the big one.
I'll just add a couple things. One, I completely agree. Be the best medical student you can be right now. Number 2, enjoy and don't lose your special hobbies or whatever it is that makes you happy. Do those things, because that's honestly, it's the things that will keep you sane during residency, when you're just busy and you're just going every day, you're just like going forward. Being able to have the time to cultivate those things is that outside of medicine is important. And then the last thing I'll say is, just because you're in training doesn't mean your life has to be on hold. So like whatever it is that's important to you, that's in moving forward with life, just keep doing those things. So we all make time for what's important somehow, and those things will bubble up as you progress through each stage of your training.
Yeah, I think I'll just say make sure you love it, because I think it's a great field, and I think everybody sort of ends up finding their specialty. But I just think you're so much more set up for success and enjoying each day and enjoying the journey if you know that this is really the field for you and that you really enjoy doing it.
Thank you so much to all the panelists. Before we finish up for tonight's session, I wanted to also introduce our faculty sponsor and Professor of Vascular Surgery at Mount Sinai, Dr. Daniel Hahn.
Hi, thank you for the panelists and everyone for doing this event tonight. I'm just coming on to put in the final plug for the society that we're all a part of, that all the attending panelists are here. We're all members of the Vascular Endovascular Surgical Society. And this vascular surgery interest group has been a labor of love by a lot of the students that you've heard from today. Did you like what they put on? By all means, come on to all the future events they will plan together. Do you think there are things they can do better? Become members, and we'll definitely help them participate future things that they can do. Ideally, all the attendees here are here for your resource. If you want us to do something for you guys that will be a valuable experience that you think could help your local institutions, or you just need mentors that need to be there for you, just all of us are here at your beck and call. So I'd also want to introduce my partner in crime, Max Wohlauer, who's the chair of the student education section for the VESS, to give his final words before the end of the night.
Thanks everyone for attending. Thanks to moderators, and thank you VESS VSIG for putting on such an amazing event. it's really inspirational, having over 100 med students on for this whole hour session. High yield and really great talks, and thank you, everyone.
All right, thank you so much. So let's give our panelists a big round of applause, and feel free to now turn on your cameras and show your appreciation through the reaction emojis. This wraps up our panel. Any outstanding questions from the chat will be posted online at a later date on the VESS website. And please make sure to complete the post-panel survey through the QR code as you see on the screen. If you'd like to join committee and help with future events, please reach out to us as well through the email listed. Thank you so much.